experience on Paris and with the Parisian patients.
Good morning, dear all. Mr. Chairman, dear Tom, Jude, thank you for inviting me presenting this short French story. And I have entitled my lecture, Chrono Physiopathology of COVID-19 pulmonary infection. So please, can I have the next slide, please? So I have few slides, some of them are very heavy. And let me point out for you the main step. In this slide, I detail the physiopathology of COVID-19 pulmonary infection. Usually it begins by interstitial lung injury, then hypoxemia occurs, then the patient self-injure his lung, and finally the parenchymal lung injury occurs. And these three steps are very important. Interstitial lung injury beginnings with all the physiopathology described in my slide, intense hypoxemia, which can be intense, then the patient self-injure his lung due to negative inspiratory pressure and very large transpulmonary pressure. And finally, a very strong illness occurs in all the parenchyma of the lung, and it's called the parenchymal lung injury. Next slide. If we go to treatment of this pathology, you can see that there are some therapy: virucide, anticoagulants, corticoids, anti-inflammatory, bronchodilators, and sometimes when parenchymal injury is too important, we have to sedate, paralyze, and mechanically ventilate the patient after tracheal intubation. And we need to give them antibiotics. But the most important thing I would like to express to you is that we can break the vicious circle that promote from interstitial lung injury to parenchymal lung injury, and we can break this vicious circle by using oxygenotherapy. Next slide, please. And this is the major steps: interstitial lung injury, severe hypoxemia. Usually the patient at this step are present hypocarbia or normal carbia, then occur the self-induced lung injury, and finally it ends by tracheal intubation when the patient has parenchymal lung injury. Next steps. So this is the place we place oxygenotherapy to break the vicious circles. Interstitial lung injury occurs sometimes without any symptoms. We discovered this pathology when making systematically CT scan to the patient. Hypoxemia, it's a standard for this patient with lung infection. They become very quickly hypoxemic sometimes. We need to give them oxygenotherapy to limit the risk of self-induced lung injury or parenchymal lung injury. Next step, please. So we decided there would be 4 major basic specifications for the ideal device to give oxygen to these patients that are not sedated, they are fully conscious, and they need high flow oxygen, high peak flow system. They need a pressurized expiration to treat pulmonary edema and shunt, and they need inspiration pressurized to limit ventilation fatigue. So we need 4 things: high flow oxygen, high peak flow device, pressurized expiration, which can be obtained by PEP, PIP, or CPAP, and to limit ventilatory fatigue, diaphragmatic fatigue, or accessory inspiratory muscle fatigue by pressurizing inspiration using IPAP or BiPAP. Next slide. So these are the different available systems to pressurize oxygenation. We can pressurize only inspiration, IPAP on the left. Then we can pressurize expiration, this is PEP or PIP. We can pressurize both inspiration and expiration, this BiPAP. We can have a continuous pressure during inspiration and expiration is CPAP. And finally, we have some particular interest for B-level PAPE, which means that for four respiratory cycles, there will be a continuous pressure. Then this pressure will be increased for the next four respiratory cycle, and then decrease to initial B-level PAP. These are the way we can pressurize oxygen, and patient need oxygen and pressurizing the airway. Next step. So which of these machine or device complies with our basic specification? We decide ICU ventilators, perfect. Operating room ventilator, perfect. Transport ventilation, okay. Optiflow, okay. But we have also some pocket device that are doing very well. Next slide. All of these devices complies with the four basic specifications we define. Next slide. So based on this, we try to define the major specification for ward use. And these are the specifications we use in Paris, but we defined before. Perfect tolerance. The patient is not sedated. He must wear his mask and be comfortable with this. It must be safe. And we describe an open system, which means that when the system is open, there's never overpressure. There's never leak on the mask. It must be safe for the caregivers, which means that some oxygen devices are delivering so massive flow of oxygen that some droplets may drop out when they are breathing. When you put the Optiflow, you have 60 liters in the pharynx. This oxygen is not inspired, so it goes out the pharynx, and this is droplet production with infected virus in these droplets. So the system has to be safe for caregivers and for the environment of the patient. It has to be easy to assemble, no sophisticated setting. It has to be strictly portable. It has to permit the patient to mobilize. It can be installed or reinstalled by the patient himself. And it is light to wear on the face and usable in all positions, awake or sleeping, prone, lateral, but also sitting in a chair. So the patient has to be quite mobile and can be able to wear his system during the treatment, oxygen treatment. And in the context of Solid Dhonneur, which is a humanitarian association we try to set, we have added some specification. It has to be cheap. It has to be light and portable. It has to work with pressurized air and not only with oxygen. And finally, it needs to have a limited oxygen consumption. Next slide, please. So we analyzed all the device we had. All of them were fitting basic specification, but only one comply with the major ward use specification. It called the CPAP of Boussignac. It's a very high flow oxygen system. It use 3, 6, 9, 12, 15, 20, 25, 30 liters by minute. It has a very high peak flow. I think it's the highest peak flow on the market, even from ICU ventilator. We measure 270 liters per minute peak flow for this machine, maintaining a stable inspiratory pressure within the mask. We can pressurize expiration, 1 to 15 centimeters of water. We can pressurize expiration, 1 to 10 centimeters. It's perfectly tolerated. It's a full open system. You can put a pen in it, it still works. It is easy to assemble. It takes a few minutes to assemble. There's no learning curve to use it. It's a simple adjustment oxygen flow, titrated on respiratory rate and SpO2, and it is efficient, which means that it has been already validated in the literature. Thank you for your attention. Oh, excuse me, there's the last slide. It's our small experience in Paris, in France. In our hospital, Curie Institute it's an hospital, the biggest hospital in Paris for cancer treatment. And we have been protected during the COVID pandemic, because initially we were asked by the French health system to continue to treat cancer. And COVID patients were put in other hospitals of Paris. But at what time? The system told us, please, now you have to open your ICU. And we did this. And we opened the ICU to COVID-19 infected patient, non-cancer patient, which means that we were invited by such patient. And this is our experience. I calculate the days of exposition to COVID-19 patient. In the world, there had been, during the last month, 1,800 days with COVID patient. We created an oxygen requiring unit. It has been 240 days patient, 13% of the days were dedicated to this unit. We had an ICU, we had to intubate 6 or 8 of the patient, with only 3% of the patient we received. And we had a very nice experience because none of the intubated patients that were treated the way I told you in the presentation before, with the CPAP of Boussignac, placed in sitting position, in prone position while sleeping, they can reinstall the CPAP on them. They can use it anytime you want, anytime they want, and they learn how to use it. And I would say we had no death to deplore with this experience, trying not to intubate the patient, rather use oxygen under pressure. And finally, we succeeded in our treatment with no death, although some patients were intubated for 9 patients were intubated for 10 to 16 days. The last patient went out on her feet of the ICU yesterday. Thank you for your attention.
Thank you, Gilles. Thank you. We can see that your expertise in respiratory and ventilatory physiopathology is a key competency area to explain the treatment of COVID-19 patients, excuse me. I'll tell it in French. So now we...
Joel, what we're going to, I'm sorry, Farid, what we're going to do is Adriana is going to introduce Pascal, who I think is not able to join from Benin because of connectivity issues, and I'm going to present his brief presentation. Adriana?
Okay.
Yes, thank you very much. Pascal is not able to, Soraya is not able to connect now, but he's working in the biomedical engineer, as biomedical engineer